Good afternoon, everybody. To start with, I would like to thank Dr. Deepak, Dr. Vishwas to invite me to participate in this wonderful program and share my experience in managing the cases of bilateral vocal fold immobility. Bilateral vocal fold immobility can be because of either vocal cord paralysis, it could be abductor or adductor, so it's of neurological origin. So it is paralysis of both vocal cords, either to adduct or abduct, giving respiratory obstruction and breathlessness. The immobility of the vocal cords, to remain them in the midline in the adducted position, can be because of vocal cord fixation or cricoarytenoid joint fixation, dislocation, or subluxation. So you have to differentiate why patient has laryngeal obstruction with glottic incompetence or maybe glottic insufficiency. So again, going back to the pathology or etiology, the laryngeal obstruction can be because of neurological origin, that is vocal cord paralysis, bilateral vocal fold paralysis, or bilateral abductor palsy. It can be because of external trauma or internal trauma, which could affect either the recurrent laryngeal nerve or the vagus. It could be iatrogenic because of the thyroid surgery. Many other surgeries like anterior neck or cardiothoracic surgeries, they can come to us as bilateral abductor paralysis because of trauma to the recurrent laryngeal nerve. Or it could be central neurological origin as well, like myasthenia gravis, stroke, and some other conditions. There could be 5% of this patient having bilateral abductor palsy of idiopathic origin. Most likely, we say of viral etiology. There is non-neurological group which is big enough. Vocal cord immobility because of fixation of cricoarytenoid joint or the vocal cords. This could be because of local neoplasm. It could be because of local trauma, again, external trauma or intubation trauma, internal trauma, inflammatory like rheumatoid arthritis, or most common these days, radiation for head and neck cancers, which result in edema and fixation of cricoarytenoid joint, and then patient coming to the clinic with bilateral immobile vocal folds. Now we have to differentiate neurological or fixation in the OPD itself, because the management actually is just quite different in both these groups. In children in pediatric age group, most of these patients are because of birth trauma. Central neurological origin like Arnold Chiari deformity is another group, around 40% of them. Idiopathic, that's a big group actually, and idiopathic in the sense viral etiology. So you have to keep in mind a viral etiology and the chances of spontaneous recovery in around 30 to 40% of children who come to your clinic with breathlessness and showing bilateral immobile vocal cords or bilateral vocal cord palsy. With clinical features, the patient would come with, so it's inadequate glottic ching, patient has breathlessness or dyspnea. He can have dysphagia also if it is of central neurological origin. So patient may have aspiration. Change in voice, patient may come with. As we go to the cases who are iatrogenic or traumatic origin like thyroid surgery, then over time as you extubate the patient, and if both the nerves are being impaired or traumatized, then over time, so patient would have for first to start with is hoarseness of voice, and as the voice improves, as the vocal cords start to come in the midline, then voice improves because of good adduction, but then airway worsens. Again. So voice is quite good, low, but there is inadequate airway. So how you go about? First and foremost is flexible laryngoscopy. If the cause is known because of previous investigations, you can manage those primary as well as secondary causes. If cause is unknown, patient has come to you with breathlessness and the laryngoscopy shows spots in the midline, then you have to go with CT skull base till mediastinum, what we say upper mediastinum, to trace the origin of the recurrent laryngeal nerve and to look for the base of the skull base, brainstem. You can correlate with MRI studies and try to find out what's the etiology behind the presentation. Once you diagnose, either it is peripheral or central origin, or you can't find, in 50% of cases, the CT scan or the imaging would be normal, then you can term them as idiopathic. You can go with local investigations like laryngeal electromyography, PFTs, or endoscopic evaluation of the swallowing. So I think these are important, and now we have started doing this for all cases like laryngeal EMG, just to know how spontaneous chances of spontaneous recovery are there, and then to know about the airway, upper and lower part. So you have to do PFT within your clinic. Then all blood investigations, and then you can post the patient for the treatment, the final management, that is transoral laser surgery, which has been performed as the better option these days to have good outcome in the airway as well as voice and for swallowing, that is for aspiration. In dialectic laryngoscopy, you have to check fixation or paralysis by just palpating the vocal process or the arytenoid movement and then making sure it's either paralysis or fixation. Now, if it is bilateral vocal cord paralysis of neurological origin, then what you will see on phonation, on adduction, on a stroboscopy, you will be able to see good mucosal waves. See, the mucosal waves are quite present on both the vocal cords, which would mean it is of neurological origin. Now, this is a case on adduction and on stroboscopy. There is a loss of mucosal wave. See, on stroboscopy, you can't see any of the mucosal waves on either vocal cords. That means this fixation or this immobility is because of fixation of the cricoarytenoid joint, fibrosis, and then loss of mucosal waves. Just to go ahead, if it is palsy, then you can do transoral laser surgery with partial chordectomy and partial arytnectomy to open up the airway. But if it is fixation, then in most of the cases, you have to explore them transcervically or open surgery and do expansion laryngoplasty with posterior cricoid split and a cricoid cut and the cervical rib cartilage graft. So the different actually the management changes as per the uh, pathology. Now you can have breathlessness in these kinds of patients also. So you have to check with video laryngoscopy what type of palsy the patient has. So see, this is the right vocal cord, this is the left vocal cord, and there is inadequate adduction. So this is bilateral adductor palsy. There is no abduction. Both the cords are in pyramidal position, and the patient would have aspiration, pneumonia, and then come with breathlessness. So these cases, more and more, you will see with patients coming in with external trauma and then affecting recurrent laryngeal as well as superior laryngeal on both the sides and this type of picture. So voice therapy, then either you can try unilateral thyroplasty or unilateral fat augmentation um, to improve on the voice, but not really affecting the airway as well. Very difficult to treat these kind of patients. There are patients, especially young children who are staying in hostels. So they can come to the casualty with breathlessness. You put in the scope and you see bilateral immobile vocal cords. But when you put in the and check the saturation, it's near normal. So these are called as paradoxical vocal cord movements. So in at some times you can see the vocal cord movement. See, this patient has good airway to start with. And see, and now she has landed into immobile vocal cords. So she is not able to breathe. See, breathlessness. So again, very difficult to see. So we have to check what kind of etiological factors and what could be the management plan for these kind of patients. So the classically you put in the check the saturation, oxygen saturation is normal, and then the strider is not there, which is continuous. And on scopy, you see sometimes it's opening up and sometimes closing. So basically, these have to be managed with the psychologist, voice counseling, therapy, beta blocker to reduce the stress, maybe local Botox, and in few of the cases, you can go in for retinectomy as well. But most of these patients would psychological support, beta blockers, and local Botox would be sufficient. Now, moving toward the fixity, again, local uh, malignancy, which is resulting into bilateral immobile vocal cords or fixation. So, video laryngoscopy or video laryngoscopy is quite important to check what could be the reason for breathlessness, glottic obstruction. Good number of patients now would come to your clinic post radiation immobility. You can see the edema all around, the congestion and inadequate vocal cord movement. These are very difficult to treat. You have to manage them conservatively, and local direct laryngoscopy with balloon dilatation would be a good treatment of choice for these patients. But post radiation, at least in acute phase, don't try to go in with laser and try to do chordectomy. So post radiation, Balloon dilatation, conservative management. If there is a lot of edema, they come in acute, like during radiation, if the patient lands up, or let's say within 3 weeks to 6 weeks, then you can straight away go for tracheostomy. And then when the radiation settles down, so after 6 months to 1 year, then you can go in for definitive management. But don't go for these kind of patients with the laser chordectomy or aretinectomy. This is the laryngeal EMG we are doing in for all these cases. Uh, the advantage being to know what's the action potentials and what are the chances of spontaneous recovery. This is pulmonary function test which we are doing, and they are going to show classical graphs, and you can monitor whether to decannulate, when to decannulate. The goals of treatment: safe and adequate airway, of course, preservation of voice quality, and laryngeal competence for complete swallowing or without any aspiration. Tracheostomy has been the management for many years, maybe 20, 30 years back. Now going into transoral procedures with the CO2 laser aretinectomy, carotidectomy, or suture lateralization. You can open up with taking care of the airway, voice, and swallowing quite nicely. With vocal cord fixation, you can go transcervical or open, and then laryngeal expansion procedures. We're just going to see the classical microlaryngoscopy with partial with posterior third of chordectomy and aretinectomy. So this is the incision mark just anterior to the vocal process. With the CO2 laser beam, I'm going to mark the incision, going laterally over the ventricular band or the false vocal cord, coming back, including the false vocal cord and part of the arytenoid cartilage. In this case, I am doing only chordectomy, so I will include the arytenoid, the vocal process only.
Vaporize the tissue in the incision line until the vocal fold is severed.
This is chordotomy. I'm coming back with the CO2 laser.
Continue vaporization.
This is acute blade of CO2 laser. Now the anesthesia with high frequency jet ventilation. A small cannula going posteriorly, giving adequate exposure of the posterior commissure.
Continue vaporization in the deeper planes.
We'll find posterior arytenoid artery here, which bleeds. You have to cauterize with unipolar cautery.
Of the arytenoid is seen here as whitish tissue, which produces a flash with each strike of the laser beam. Stretch the arytenoid medially to vaporize surrounding soft tissue and remove the excised arytenoid.
This is a vocalis muscle. This is a vocalis muscle we are dissecting.
If necessary, vaporize the soft tissue to enlarge the glottis further. Use metal suction cannula as backstop to protect the trachea.
This is a scanning mode of the CO2 laser. And then you open up the larynx. Okay. Okay. Same. Just to go in for 2 minutes. So the incision going down on the arytenoid cartilage. So I'm doing partial arytenoidectomy also. So chordectomy with arytenoidectomy. This is on the right side. Exercise and finish the procedure. Some cartilage you can vaporize with the scanning mode of the CO2 laser and can get the adequate. So this is a scanning mode of the CO2 laser just to make it as a good cavity to breathe. Suture lateralization could be temporary if you want to have, if you are looking in for spontaneous recovery, you can just do a suture lateralization, and as the vocal cord mobility comes back, as the abduction comes back, you can just take out the suture and allow the patient to breathe normally. If you want to do permanent suture lateralization, in which is actually you have to do in most of the cases, then what you have to do with the CO2 laser, you have to just vaporize the vocalis muscle, the posterior 1/3, and then with the edge intact, you have to lateralize with the suture with the Lichtenberger's needle. So I have made this raw. Then I have lateralized it with suture with Lichtenberger's needle and then tying the knot. And then this is the picture which you gets the airway like this. So once you remove the suture after 6 weeks, then because of this area, there is a uh, fibrosis, and this is the airway which patient gets. So patient gets a good airway with suture lateration, but the hoarseness is more than what you get with chordectomy, because the entire cord is lateralized with suture lateralization, not like limited to posterior 1/3 in chordectomy. Cases of arytenoid prolapse with bilateral abdominal palsy. So you have to limit your surgery to the arytenoid and then open up the airway. So this is the stroboscopy showing the arytenoid prolapse. Limit the surgery to the arytenoid. Do arytenotomy, leave behind most of the vocal cord quite intact. And this is after the surgery. This immediate post-op. There is a good airway which is available. So this is 1 year post-operative of a chordectomy for bilateral abdominal palsy. So there is adequate airway available for breathing. So anterior one third or anterior half is intact to phonate, and posterior one third is giving good space for breathing. And what you see is a good mucosal waves with good airway available in the posterior one third. So this is 4 years after the surgery. So adequate airway available with good mucosal waves and good voice. Pediatric airway not to be aggressive because there are chances of post-operative aspiration. So it's better to keep nasogastric tube for 7 days to prevent aspiration after the surgery. Re-innervation has been tried in pediatric age group because they have got adequate growth factor or growth period to for the re-innervation to occur and giving them chances of vocal cord movement after that. In congenital cases which come with bilateral palsy, uh, not chordotomy really is not welcome because loss of voice for their entire life. So what people have tried is just expand with anterior and posterior cricoid split, then pass in the endotracheal tube, keep that tube for 3 to 6 weeks, admit the patient in intensive care unit, and then remove the tube and allow that to heal and give adequate airway. Still not that practical, but has been described by Mark Ritter from Cincinnati. Now, posterior aortic stenosis. Now you can see the lesion or the stenosis in the posterior glottis. So this is not bilateral abdominal palsy. This is bilateral vocal cord fixation. See, bilateral vocal cord fixation. See, you can, so video laryngoscopy is very important to check the entire glottis and accordingly have to look for the treatment options. So as we posterior glottic stenosis has been classified into type 1, type 2, type 3, and type 4. What the previous two clips we have seen are type 3 and type 4, in which there is complete posterior glottic stenosis. Now, type 1 is what we say as a partial stenosis in the posterior glottis. So there is a area which is spared in the posterior part. So this is a synecdoche only in the arytenoids. And then you have to just cut the synecdoche and open up the airway. In posterior type 2, in the posterior glottic airway, where you can find the fibrosis in between the arytenoids, maybe complete fibrosis, but there is a arytenoid movement. Then you can vaporize it with CO2 laser and do sessions of balloon dilatation. Type 3 and type 4, we have to open up the cases and do posterior cricoid expansion with the rib cartilage graft. Now this is type 1. Okay, so this is type 1. So a synecdoche between the arytenoids, sparing the posterior glottic space. And for these cases, what you have to do is just cut the graft which CO2 laser or just with scissors. But you have to protect the posterior part which is really spared, not to injure with the CO2 laser. So I have protected with the neuropathy or roller strip, and then I am cutting over with CO2 laser. And then you can have good results. So this is type 1, same type 1. Again, protecting with the bougie And this is the results. This is type 2. You can see the complete stenosis bit with arytenoid mobility. Now there are various methods available. You can do submucosal arytenotomy with balloon dilatation. See. So I've cut with laser and balloon dilatation. So type 2 and type 1 can be managed transorally with laser. Type 3 and 4, you have to open up, do cricoid expansion, put in a stent, and then decannulate. Now, glottic balloon dilatation for bilateral abductor palsy in the posterior glottis, you have to always know the balloons are spherical, so they will not apply in the triangular space. So what you have to do, you have to just pass a bougie in the anterior part of the glottic chink, then posteriorly you pass your balloon and then dilate. So there will be adequate pressure for expansion. So this is the method, or this is the skill you have to remember while dilatation of the glottic space. Okay, so just leave that. What are the risk factors of uh, microlaryngoscopy with partial arytenotomy? Is interarytenoid fixation. If you injure the opposite arytenoid as well as the interarytenoid space, which you have to avoid. This is not a most welcome complication, very difficult to treat. Again, you have to, this is class 4. So again, you have to go externally, open up and do expansion, required expansion, laryngoplasty. Granuloma, because we are working on the arytenoid cartilage, so perichondritis and granuloma formation, you just have to remove it endoscopically and give good airway to the patient. So these are granuloma. I mean, this is exposed cartilage and which has formed a granuloma after 6 weeks. You can just remove it with a flexible laryngoscope or under general anesthesia. What intra-arytenoid distance you have to achieve for good airway for daily routine activities is more than 2 millimeters. Now, this is possible with our high-speed camera. We can measure, but you have to remember this 2 millimeter. So what you have to do is take an endotracheal tube of 3 or 4 size. After you finish chorectomy, you just try to pass in this 3 or 4 size endotracheal tube. And if you can pass it without resistance, then that's the adequate airway you have achieved with your surgery, and look forward for decannulation or good airway or good results. Swallowing, I have studied, I mean, I have done endoscopic evaluation of swallowing for almost all the patients, and there is hardly any patient who will have post-operative aspiration because of compensation of supraglottic areas like false scots and arytenoids, aryepiretic folds. Voice, because of the surgical techniques and limiting your surgery only to the posterior one third, leaving behind all the vocal cords without any thermal trauma of the laser, you can have a good mucosal wave and good voice. This is during adduction, and you can see the mucosal waves on a high-speed camera. So these nice mucosal waves would give good phonatory outcome for these patients with transoral chorectomy, arytenotomy. Okay. Now the patients who have got bilateral cricoid joint fixation, you can vaporize them with CO2 laser and make them mobile. So actually, this is one case who had come with interglottic web, but you can see arytenoid movement. So arytenoids are not fixed, but sorry, the arytenoids are fixed, but you can see the contraction possible. So we have done vaporization of the arytenoids and mobilization of the arytenoids, and this is after 1 year. So there is a good vocal cord movement which has been regained. There are new techniques coming up with laryngeal pacing, like cardiac pacing we do. So you can just pass in a chip there in the vocal cords, stimulate the chip, and try to have vocal cord movement, which can be covered. So maybe now Elon Musk would develop next to the brain chip, the vocal cord chip as well for laryngeal movement. Again, laryngeal reinnervation has been tried even for bilateral abductor palsy. There are various techniques. And gene therapy, stem cell therapy is the newest thing which has come. So you just inject these growth factors, these stem cells into the vocal cord and wait for the reinnervation. So these are neurotrophic and growth factors that are available. And this is a new research which has tried to regain the vocal cord mobility. Thank you very much for listening to the lecture.
Thank you, sir.